Thank you so much, Dr. Run. So I'm Zhen Jin, one of the consultants in the Department of Bariatric Surgery. So just give me a minute while I share my screen here. Okay, so I hope everyone had a good morning. So I have no disclosures. So I'm here to talk about the surgical management for obesity and metabolic syndrome. So to just put it in a simple summary, bariatric surgery itself is divided into two main types. What we term as a restrictive, and the second type will be what we term as a malabsorptive. So restrictive basically means that we restrict the amount of food that is taken in, and a malabsorptive procedure will actually is referring to a type of surgical procedure where we actually prevent the body from absorbing all the nutrients that is taken in. And all in all, it actually changes the passage of the nutrients that goes through our system. And by doing so, this changes the body's appetite level and also changes the secretion of certain hormones, which will then lead to weight loss. So this slide, basically what I'm trying to show is that surgery itself has gotten pretty mainstream. If you read the papers, magazines, you'll find that actually it is not something that people don't talk about anymore. And quite a lot of people actually do go for surgery to help them in weight loss. So I would like to actually go through a couple of the common surgical procedures that we do here in FGH, or rather in Singapore. And we'll talk a little bit about what are the complications that entails in surgery and what to look out for. And then I would also like to touch on a little bit about how we go about making the choice with regards to surgery or non-surgical options for weight management itself. So one of the most common procedure would be that of the sleeve gastrectomy. It was actually first thought of as a first step of a very complicated procedure previously for weight loss. And when they found that when they just do this procedure, the patients itself actually lost quite a lot of weight and even had a resolution of their comorbidities such as diabetes. And the surgery itself was also very straightforward. So eventually, this procedure known as the sleeve gastrectomy was then subsequently adopted as the primary procedure of choice. So what happens during a sleeve gastrectomy is that we use a stapler and we cut the stomach away on the right side. So a large portion of the stomach is removed. And what is left behind is actually a very narrow banana-shaped stomach. So this is actually what we term as a restrictive procedure. By making the stomach into a narrow tube, it reduces the amount of food that you are able to eat in one time, in one sitting. And when you reduce the amount of food you take in, then calorie intake drops and weight loss would then follow on. The other thing is that the portion of the stomach that is removed, also known as the fundus, produces a hormone known as ghrelin. And when that's removed, it's kind of like a hunger hormone. Then the sensation of hunger is no longer persistently there, which also then leads to lower oral intake also. So the outcomes for patients who undergo a sleeve gastrectomy, most of the weight loss is actually achieved within the first 2 years of around 30 to 40% of excess of body weight. And at about 5-year point, we found that the patients actually do have sustained weight loss, even though over a long period of time, a portion of the patients may experience some weight regain. And what I always tell my patients is that the stomach is a muscle. Muscle can stretch, and we may do experience some form of stomach pouch expansion after a long period of time. But all in all, the sleeve gastrectomy surgery complication rate is actually quite low. Mainly what we are most worried about is staple line leak. When we cut the stomach, we actually use a stapler, leaving behind a row of titanium staplers, which is actually quite unreactive. The body will heal over the staple line. There is a very, very small rate of 1 to 2% of leak from the staple line if it doesn't heal properly. But we have ways to deal with it and treat it. And we always will keep a lookout for any form of small, even though the complications rate are low, we do keep a lookout for it. The other thing is that about 30% of patients may actually experience some form of reflux after a sleeve gastrectomy. But most of the time, once again, it's also quite amenable to medical therapy, meaning we give medicine to reduce the amount of acid in the stomach, and most of the time the reflux is well treated. The reason why this sleeve gastrectomy is a very popular procedure is that it is actually quite straightforward, and also with good results. I would say in the most parts of the world, it is one of the main surgeries that is done for weight management. Okay, and what some of the situations is that if let's say we have a patient with a very, very high BMI, it can also be adopted as a two-stage approach. That means we do a sleeve gastrectomy first for the patient to help them reduce some weight. And then we can then do a conversion surgery to help them lose even more weight. So in that sense, the sleeve gastrectomy is a very flexible option. If let's say after 2 or 3 years later, our patients feel that they have not reached their goal weight yet, we can always discuss about conversion to another type of surgery, such as the bypass, to help them reach closer to their ideal weight. Okay, the second surgical procedure is known as the Roux-en-Y gastric bypass, or simply known as the gastric bypass. So this is one of the previously most popular bariatric procedure worldwide, and has been long considered the gold standard in bariatric surgery. And in fact, in some parts of North America, it's still the most commonly performed procedure of choice. There are a few reasons why, and then I'll share them with you later on. So the surgical procedure itself involves the 2 steps. So first part is we actually make the stomach into a small pouch, which is roughly about 30 mils in size. And then the second part is that we bring a loop of the small intestine up to join to that small gastric pouch. By doing so, we bypass the first part of the small intestine. Therefore, this name of the surgery is known as the gastric bypass. So there are 2 components to which the patient loses weight. Firstly, because of the small gastric pouch, it also reduces the amount of food that a person can take in one sitting. And then the second reason is because by bypassing and the first part of the small intestine, the food doesn't come into contact with these portions. And then this results in some hormonal changes and some resulting in a suppression of the appetite, and also leading to what we term as malabsorption, reducing the weight as a result. Okay, so this diagram shows that on the left side of the screen, you see the red dotted line, which indicates the creation of the small gastric pouch. And as you see on the right side of the screen, that image, when we bring that loop of intestine, which is shaded in yellow, up to join, we bypass the upper parts of the stomach and the first part of the small intestine. So the gastric bypass is thought to help weight loss in a few ways. So once again, the small pouch restricts the amount of food that can be taken in at one time. And the rearrangement of this intestine reroutes the transit of food further down into the small intestine. So the food itself that you take in does not touch the first part of the small intestine, resulting in metabolic and hormonal changes, which then reduces appetite and increased sense of fullness. So for the outcomes wise, as compared to the sleeve, there is more weight loss. We are looking at roughly about 50% of the excess body weight. And once again, maximally during the first 2 years. And when we look at long-term data, because this procedure has been done for a long time, the patients are also able to maintain the excess body weight loss of about the same amount in a long period of time. And more importantly, is that several obesity-related diseases are found to dramatically improve after surgery. And this actually includes type 2 diabetes, hypertension, high cholesterol, the metabolic syndromes, as what we mentioned earlier on, the fatty liver, and also in patients with snoring, such as obstructive sleep apnea, actually found that actually improves also. And more than 50, and studies have actually shown that more than 50% of the patients with type 2 diabetes also actually experience that their blood sugars actually normalize, and a portion of them actually don't really need any more diabetic medications after that. Okay, so as similar to the sleeve gastrectomy, complication rates in general are also low, with a very low risk of mortality of less than 0.2%. So the main risk of complications are generally the general surgical risks experienced in all types of surgery, such as bleeding, infection, some clot formation, and they are quoted in the range of less than 5%. And some people also do find that it's almost as safe as gallbladder surgery itself. But most importantly, I would say, as compared to the sleeve gastrectomy, the bypass because we bypass away from the lower portion of the stomach and the first part of the intestine, there may be some significant vitamin and mineral deficiency, such as iron, vitamin B, calcium, vitamin D. So we do need to work hand in hand with our dietitian and also ensure that our patients do get proper vitamin and mineral supplementation. And as with all bariatric procedures, even though the surgery has been done, weight loss has happened, we do always keep them in our program for a long-term surveillance and also on follow-up in our clinic also for mineral and vitamin supplementation. The last one, last surgical procedure I would like to share is termed as the one anastomosis gastric bypass. This is similar to the previous bypass procedure, but less complicated. And in the last few years, it has been gaining traction and has been becoming more and more popular, especially in the Asia area. And there have been many studies that has been done showing that it is actually a very safe, effective procedure, and also technically also as fast as a bypass itself. And there are two steps to it. First, we make also once again a small stomach pouch, and then we also then now bring a loop of intestine up, but we only join one part of the intestine to that stomach. So this is actually denoted by that yellow portion. So it shows a narrow stomach that has been created, which is a small pouch, and then we bring a loop of intestine up to join. And also similarly has shown to have comparable weight loss as compared to the bypass in the range of about 50%. And also studies have shown good resolution of the comorbidities such as diabetes also. And similarly, because we bypass from the first part of the small intestine, we do need our patients to be supplemented with some vitamins and minerals also. So nowadays, almost all of our surgeries are done keyhole, which means it is done through small little cuts, each one roughly about 1.5 cm or smaller. And the medical term for that is laparoscopic. And in some suitable procedures, it can also be done by the robotic surgery approach, where we use a robot controlled by the surgeon using a console. That means we sit down and then the robot is able to perform precise surgical steps. So here I would like to just share a surgical video where we use the robot to do the surgery. As you can see, this is where we join the stomach to the small intestine, and an example of how the robot does stitching here in a very seamless, a very smooth way is being displayed. Okay. Okay, so there are some things that we need to discuss even though the complication rates are low, some of the main things that I usually would tell my patients to expect after the surgery generally would be wound site pain. The pain is not much because it is a small keyhole approach, so the cuts are quite small. We will give adequate painkillers, but usually the pain is quite well tolerated. You are able to walk around right after the surgery itself. And most of our patients actually go home quite quickly within 1 day. Other things that we do want to look out for, especially in the long term, would be what I mentioned earlier is the leak. We use staplers to join the intestines together. So the body must be able to heal the joining areas properly. And there is always that small 1 to 2% chance where the joining doesn't take and there may be some leakage. Usually after, if that does happen, we will be able to pick it up through any presentation of fever or extreme pain. We'll do some blood tests, and that may require some prolonged antibiotic treatments. Other things would be such as hernias, marginal ulcers where the joining area may form small ulcers. Once again, very low rates of that, or less than about 1 to 2%. As mentioned earlier, nutrition, some of our patients will require long-term mineral and vitamin supplementation, reflux. And of course, once again, because the stomach is a muscle, the muscle itself may stretch. And usually after 2 years, where you may get quite comfortable and complacent, you might eat a little bit more. And that's when around the 2-year mark, we may experience some weight regain. But once again, in our centers, we do have experience on how to manage this kind of weight gain should it happen. So as mentioned, the post-operative procedure is quite straightforward. Some of the surgeries can be done as a short stay ward, meaning that right after the surgery, you'll recover in the special recovery area and can go home at about 8 a.m. the next day. Otherwise, most of our patients actually just stay for 1 night and can be discharged the next day in the afternoon once they demonstrate that they are able to drink a certain amount of fluids. We usually get our physiotherapists and our dietitian team to review on day 1 before they go home. And also one of our specialty bariatric nurses will also come by to give some advice and also to give a point of contact once they go home. If they encounter any issues, they can contact the team directly. Okay, follow up with the doctor is usually 1 week after discharge. We will usually put you on 2 weeks of liquid diet before progressing to soft diet as guided by the dietitian. Okay. And so who would be suitable for surgery? So the local guidelines states in patients with BMI of 37.5 with or without comorbidities, that means any other health problems, or if you have poorly controlled diabetes, high blood pressure, then a BMI of 32.5 and above will put you as an eligible candidate for surgery itself. Okay. So when it comes to weight management, I will always emphasize that it is a multidisciplinary effort. It takes a good team of the dietitian and the physio to work on a good diet and exercise program. Then we have our medical endocrinology team to help with the medical pharmacotherapy, as what Dr. Tan earlier has talked about. And then, of course, surgery also. We don't always jump straight into surgery. At the end of the day, all these 3 things are complementary to each other. But I would like to also share some evidence if we were to only embark on surgery alone versus medical treatment alone. So when we compare all these options, one of the key benefits about surgery is that the weight loss itself is a little bit more long-lasting. There is long-term data regarding the effectiveness and the safety of bariatric surgery available. And in many countries, it is actually part of the treatment plan for diabetes management. And as mentioned earlier, there have been multitude of studies that show vast improvements on the metabolic syndrome itself, and also leading to better quality of life, such as in patients with chronic pains in the joint, such as knee pain, leg swelling, and even patients with obstructive sleep apnea or snoring. So there are studies that show that if, let's say, comparing a person who goes only on medical treatment versus surgery, they found that actually in this study, after 1 year, patients who only go on medical treatment itself, a smaller proportion of them actually achieve the desired diabetes treatment target, whereas compared to a larger number or proportion of patients who underwent surgery, more of them actually reach the targets for diabetic treatment. And also, I think there are many articles about these medical treatment also reporting about when you stop the medications, actually there are reports of weight rebound. And there are also studies to show that once after a year of treatment, once the treatment is stopped, quite a fair bit of the weight also was regained, and the cardiometabolic benefits that has been achieved during this period of time when you stop the medical treatment actually bounce back to baseline levels also. So I would say that eventually, once again, it is a multidisciplinary effort. Surgical and medical treatment are complementary to each other. Surgery should not be seen as a quick fix to weight loss itself. And even after, if you undergo surgery, a healthy lifestyle incorporating a good diet and exercise is still the key to maintaining good weight management. And as mentioned earlier, in the event of a post-surgical weight gain, we always consider medical therapy first before considering any revisional surgery to deal with the weight gain itself. So in conclusion, I would say bariatric surgery is effective intervention, and medical and surgical therapy are both complementary to each other. And whether or not to choose which type of treatment, I would say personally, I would take into account my patient's profile and also their risk appetite also with regards to undergoing for surgery, and of course, eventually our patient's choice. Thank you.